this session is one of the main sessions of the day. It is about aims of therapy, divided into two sections. Newly diagnosed, that will be newly diagnosed in transplant-eligible patients, then newly diagnosed in transplant non-eligible patients, followed by refractory relapsed myeloma. So the format of the day now, this session will be that I'll present two cases of newly diagnosed myeloma, followed by Jenny presenting a case of relapsed myeloma, and straight after that, we will have Dr. Yong talking on the newly diagnosed myeloma. So my first case is, so these are all new cases. So she presented in December this year, 71-year-old lady, presented with backache for 18 months, and she had multiple telephone consultations with the GP and received various painkillers. She got so sick of her pain that she went for a private MR scan that did show vertebral collapse, unfortunately was reported as osteoporotic collapse. She was in unbearable pain, felt dizzy, fell in the house, and hence ended up in A&E in early December 24. In A&E, her calcium was found to be 2.92, creatinine was 100, but she was quite small, hemoglobin 69, total protein 87, globulin 47, albumin 40, and she had an IgG kappa paraprotein of 26.5. Bone marrow showed 80% plasma cells on aspirate and a heavy infiltrate on trephine. And if you remember, she is 71 with no other medical conditions in the past. Her FISH showed translocation 414 and deletion 1p32 in 80% of plasma cells. PET CT scan showed extensive lytic lesions. Her ISS was 3, RISS was 3, beta-2 was 8.8 and LDH 218. Her performance score was poor because of pain, but she had no other medical history. So what would you do here? Would you give A, B, or C? A is daratumumab, dara-VTD times 4 with intention to transplant with either a reduced intensity transplant or full intensity transplant, followed by consolidation with dara-VTD, followed by len maintenance. Or for this lady, would you choose dara-VTD with intention to transplant, continual fitness assessment, and switch to dara-lendex if she was unsuitable for transplant, or would you give dara-revdex? Close poll. Yep. Seems like in between approach so that we are aware of her, but still treating her with dara-VTD. So she had no past medical history, performance score was slightly low, so we commenced on dara-VTD on 17th of December. 4 days later, promptly admitted with severe sepsis, CRP of 300, no focus, AKI, GFR was down to 17. And in that particular admission, over 2 or 3 weeks, she deconditioned. She was fluid overloaded and actually DNAR'd on 24th of December. In this much time, not just this month, this week, but in the last 18 months, she had lost 4 stones of weight and 6 inches of height. And she had almost given up, and she went home with pending decision about any further treatment. So she had basically had just 1 DARA, 1 Velcade, 4 days of thalidomide, and 1 dose of Dex. She looked, on the clinic on 23rd of January, she looked very fragile. Her performance score had improved to 1. She was kyphotic with reduced lung volume, very high risk for transplant, but her globulins had fallen from 47 to 22. It seems clearly to me that her paraprotein had fallen significantly, and she had high-risk myeloma. Do I move her to dara-revdex now, or do I give a little bit more Velcade on dara-VTD? Or do I just say that, as she wanted before, no treatment? She's only 71 with no past medical history. So we decided, because she had translocation 414, so I said that let's just give dara-VTD with continual assessment for eligibility for transplant. If you become eligible, then we will think about the conditioning. But if you don't, then we can move to the dara-revdex, but until at least for 3 or 4 cycles, let us give a little bit of Velcade. Whether we did the right thing or not, Kwi will tell us. And the decision was because 414 was there and that she has high-risk myeloma. I'm coming to my case 2, and this is for Charlotte. Hey, I don't know what happened. Previous slide, please. I haven't shown my previous case. So case 2 is something else is here. He's another patient, 80 years old, widower, lives alone, presented to GP practice feeling unwell on 17th of January this year. He had again no significant past medical history. His performance score was 0 to 1. The GP did the blood test and found this. Creatinine of 709, calcium 2.39, hemoglobin of 78, acutely admitted to renal ward. They do immediately CT urogram, showed multiple lytic lesion in the spine, and then the myeloma screen they do, of course, and that was done, and he had light chain myeloma. Yeah, he had free lambda myeloma. Bone marrow showed multiple moderate-sized plasmacytoma and trifine. Congo red was negative. PET CT scan showed multiple lytic lesions. And as you can see, he was emergency treatment for AKI due to myeloma and commenced on 3 times a week dialysis. What would you do next for this patient? Would you give him Dara-Rev-Dex, dose-adjusted lenalidomide because he's in renal failure? Or would you just give dexamethasone 40 milligrams for 4 days, dexamethasone 20 milligrams for 4 days? Or would you give bortezomib and dexamethasone together? Am I spoiling your presentation, Charlotte? Yeah, everybody has said continue bortezomib and dexamethasone, 50%. Some have given VD. I do want to give him Dara-Rev-Dex, but once his kidneys get better. So his kidneys did get better. He's come off dialysis. So would you continue Veldex, or would you give VMP for 13 cycles? Would you give VCD, or would you continue with just VD, or would you move to Dara-Rev-Dex? And the answer has already been given, many of them. So many of you have said that, move to Dara-RD. So these are my 2 cases. Just shows that even though we are boxed into Dara-VTD and Dara-Rev-Dex, that boxing is perhaps not appropriate for all the patients. And that is the reason why our newly diagnosed patient talks are going to be very important for us. I'm going to move over, hand over to Jenny to talk about refractory relapsed case.
I'll be very quick because I know you're waiting. We're just going to do the cases at the start. So there might be some issues with the voting slides, so we might just move past the voting very quickly. So this is hopefully a case that is similar to what we see in the MDT, unfortunately, but just as an illustration. So this is a 56-year-old man, only past medical history, non-insulin dependent diabetes, ECOG 0, lives in a remote location without good transport access. So he presented in December 22 with biopsy-proven plasmacytoma and a spinal cord compression at C7. Imaging showed lytic lesions throughout his skeleton, and one of these was biopsied confirming plasmacytoma. Myeloma screen showed no paraprotein, modest increase in free kappa at 367 with a ratio of 141. So went on to get an aspirate and trophine, and in fact his plasma cells were not increased on that sample, and his FISH was also negative for high-risk cytogenetic abnormalities, and the aspirate and trophine wasn't repeated. ISS1 or RISS1 as well. So he was treated with standard of care, as was the case in December 20, with VTD times 6, auto, and then LEN maintenance. Started LEN maintenance August 21, just as it had been approved by SMC. He had toxicity of grade 1 peripheral neuropathy through his induction, but that had subsequently improved and had resolved. Unfortunately, we saw an early biochemical progression with rise in his serum free light chains in January 2023. So that was therefore just under 18 months from his auto and commencing LEN maintenance. So really just, if you can think to yourselves what you would do now. So obviously we're looking at second line treatment options. So in terms of UK practice, what we have is DVD until progression, or carfilzomib and dexamethasone, obviously given that he was LEN refractory. Would you do a second auto, and would you use your induction as carfilzomib, dexamethasone, or DVD induction, obviously then without maintenance following your second auto? So you can kind of think about what you would do, and then what we did. So we treat it with DVD until progression. It's kind of easy to give DVD as a regimen. Patient received 9 cycles from January to 2023, with best response being a VGPR. Second auto was not undertaken because of the short PFS1 of less than 18 months after his first auto. Once again, unfortunately, we saw this slow biochemical relapse occurring in October 2023. Unfortunately, this time imaging also showed a clinical progression with a new plasmacytoma within the pelvis. So this gave him a PFS2 of 9 months, so 50% of his PFS1. Despite this, he remained ACOG 0 and was reasonably well. So then we're thinking, well, what do we do now? So we're now looking at third-line treatment. And just to point out, because this was a patient in Scotland, we do have access to carfilzomib and dexamethasone from second-line onwards, which I know is not the case in NHS England. Panobinostat, Bortez Dex is an option. Pomalidomide and Dex is a doublet, or cyclophosphamide and dexamethasone. So again, this kind of highlights that in that third-line space, we probably don't have the best array of treatments, and it's trying to work out what to do. So again, if you can just think about what you might have done in this situation, bearing in mind this is 2023, and what we did, so rightly or wrongly, we gave carfilzomib dexamethasone for 8 cycles. So we got that from November 23 through to August 24. Best response again was VGPR. Unfortunately, then the same pattern emerged with a rise in his light chains, and this time quite significant skeletal progression with horrible bilateral clavicular fractures that were painful and affected the patient's functional status, requiring him to come into hospital for radiotherapy and pain management. So again, we had a PFS3, this time of 9 months. So what do we do now? So we're now on to fourth-line treatment, bearing in mind this patient is diagnosed in 2020, and by 2024 we're now at fourth-line therapy. So we know this patient is not doing well, functional high-risk disease. So these are our options. Again, because it's Scotland, we can use Isopom Dex at fourth line based on the theory that there is maybe still some benefit in isatuximab from a Dara refractory patient because it acts through a different epitope, whether that's the case or not, but it is available to use. Or your doublet Pomdex, Panobinostat. Selinexor, Bortez Dex had just been approved at this point, but we also were aware that the bispecific antibody approvals were likely to come in September 24, so we were thinking about that ahead. So what did we do? So we actually just went with Isopom Dex, and unfortunately within 2 cycles the disease bounced off this. So his free kappa went up from 138 to 661 over 2 cycles, so clearly refractory, but nasty bony progression. This time lots of bony disease, lots of pain, and now a new plasmacytoma, new soft tissue mass with destructive iliac bone lesion. So the patient was in trouble. We admitted the patient at the point that we'd just got access to elranatamab, and that was started in October 24, and 6 months later the patient has responded, is in a serological CR, and no further bone lesions by imaging. So far so good, but just an example of a patient with functional high-risk disease. So we'll then introduce the speakers because we've been standing waiting. So Kui Young, don't think you need any introduction, but yeah, so if we just can get Kui's slides